And so when we look at our map today, the blue dots represent our post-acute care facilities. The green dots represent our acute care facilities. These are all nodes of which we're sharing information across the care continuum real time. So when patients come to the emergency department, you get a snapshot of where they've been, what medical problems they may have, what care has been provided. What I like to say is this is almost like an EHR of sorts that's a mile wide and an inch deep. Again, we're not as comprehensive as some of the other EHRs, the Cerners and the Epics out there, because their role is very different. Ours is to create a standard presentation where you can actually get actionable, digestible information. So being a post-acute care company and now adding the acute care aspect to this, one might ask, like, how can we leverage the post-acute care that data that we have and the post-acute care facilities that we serve into the acute care world? I mean, there's no question, there's no secret that it's disconnected care. As a practicing ED physician, we know that every time a patient comes from a nursing facility, a skilled nursing facility, a senior care facility, an LTAC, there's oftentimes a breakdown in communication. There's a limit of records that can be shared between the two facilities. There's often a breakdown in the reason for transfer. And at no point in my career have we looked at this and we said, hey, listen, how can we partner with a post-acute care facility to drive quality? It always seems like an arrangement built for that, right? It's built more for, we are the emergency department, we're receiving a patient, there's a breakdown in communication, and quality never comes on the radar. And then to extend that, how about the cost? Again, we never think about the cost that's really incurred. I should rephrase that. We do think about the cost. If you're in the ED, I can't tell you how many times one of myself or one of my partners has said, man, how much is this costing for a abnormal urinalysis that could have been treated in the nursing home? But again, this all comes back to communication. And so what you'll see is, and what if you practice just an hour in the emergency room, what you'll see is that these patients are coming really in a way that nobody else comes. I mean, even from the street, we have more information oftentimes than from a facility that has an electronic health record. And as the provider in the EHR of over 13,000 post-acute care facilities in the US, I think it's our responsibility to figure out how to solve this. So here's one of our most famous patients that we love to use as a model patient, Ramesh Patel. He's an 88-year-old gentleman who resides in a senior living facility. He has congestive heart failure. He's had multiple falls. He's been to the ER and to his primary care a few times over the last week or two. And now he has another fall. And so oftentimes as the ED provider, I'm in the ER and I hear we're getting a patient from ABC Nursing Home and we're not really sure what their problems are. And what do they come with? They come with a yellow envelope often, right? And it almost looks like what do they call this? A ream of paper, right? It's about this big, and they just sort of hand it to you, and it's got an MAR from like 1987, along with a discharge summary from 2 years ago. And so it takes time. It's not useful. And so how can we provide that information that is useful, that is actionable at the right time, at the right place, to make a difference in both the quality and the cost of care? And so here's Ramesh. That call is made to the PCP that covers the nursing home. Probably either the call goes unanswered or it's a very short phone call and they say, call EMS and send him to the ER. And so I'd like to talk a little bit today about two things. One is ED optimization, and then the second is our SNF summary. ED optimization is the sort of the heir apparent to EDI, Emergency Department Information Exchange. We call this EDO or ED optimization. What does it provide? It provides enough information that I like to say it answers about 60% of your questions. It provides what their name is and who their physicians are, what their phone numbers are, what their diagnoses are, what their medications and allergies are, and what their visit history looks like. Not all patients will have an EDO report, but for different benchmarks that you might be looking for, whether it's 30-day readmissions or patients that have more than 5 visits over a 12-month period, you have a lot of insight into what might be an opportunity for case management, care management, reduction of resources, utilization management, and whatnot. And so it's really an insight that lives within your EHR. It's actually on the track board for Cerner or Epic. A lot of other EHRs have the opportunity for it to live in there. And then, when I started using this product 12 years ago, it was the good old fax. And again, it was transformational at that time to be able to get that kind of information, not 3 hours after you saw the patient, but actually 3 minutes before you saw the patient. And so that was really helpful. Along with this, we can look at some of the more vulnerable patients that we serve, maternal health patients. I currently live in Alabama, and we have a really difficult time with maternal health. We have some of the worst mortality in the country as a state. And how are we going to address this? And as we've done a deep dive on it over the last 5 or 6 years, one of the things that we've learned is care is one thing, but understanding where these patients access care and what diagnoses they have, it would be a lot better to know that on the front end rather than reading a death report and knowing that they were depressed and nobody knew they were depressed. And so how can we bring actionable, digestible information real time to the treating physicians and providers to make a difference, to improve quality and reduce costs? And so this helps improve ED point of care decisions. I use the example of the patient that comes in with abdominal pain and maybe visits other ERs in your area, and they've got 9 or 10 visits, and they've over the past month. And you think to yourself, well, every discharge diagnosis was abdominal pain. How long does it take to do labs and do a CT scan and wait for a read and treat with medications when you could go back and you could say they had a CT scan yesterday for the same presentation? But if you don't know that exists, you'll never ask the question. The second part is we talked about the high priority populations, but remember the value here for a product like this versus others, and that is that this push versus pull concept, right? I share this a lot, but the way that I like to think of it is, when's the last time a nurse from upstairs or a doctor from upstairs called the ER and said, hey, do you have a patient that I can admit, right? We live in a push society. And the problem is we have all the access information. We don't need more information. We need more accessible, digestible, actionable information. And so being able to push a 1 to 2 page report that comes to you that's A standard, B pushed, and 3 actionable is something different than anything that we've got today in our practice. And so while that seems simple and it seems like, well, is it very much different than Care Everywhere? The answer is yes. And I can tell you from practice, using that EHR, using Care Everywhere, and then having this applied to my practice, it is absolutely transformational. And the last thing I'll say is, how do we improve through data and through tools, efficiency, throughput? How do we bring an ROI to a product like this? The essence of our product is to improve quality, reduce costs, and reduce waste. But at some point, we've got to get more efficient. And so being able to use information to reduce unnecessary testing, to reduce the length of stay, to be able to intervene on patients where you previously didn't know you needed to intervene. One anecdote, when I was using this product many years ago in Washington State when it was Eddie, I'll never forget, we had a patient that had 57 ED visits by July year to date. And every time she came into the emergency room, she couldn't even articulate why she was there. And so she was calling EMS, and they were just bringing her to the emergency department. It turns out she just felt lonely. After we did a deep dive, we were able to get our care collaborators involved and our social workers. And it turns out, we asked her, we said, what do you really enjoy to do? And she said, I love going to eat Mexican food. And we said, hey, do you think we could help provide you a gift certificate to go eat Mexican food if you were able to figure out other ways to resolve your loneliness other than call 911? And she said, absolutely. 9 months later, 0 EMS calls, right? And again, what does this mean? We're not trying to keep people out of the emergency department that need to be there, but what we're talking about is offloading a system that oftentimes when we do an inventory of who we are and where we're at, we're not 70%, 80% overloaded, we're 10% overloaded, we're 20% overloaded, and that's an opportunity to really make a difference. So we talked about SNFs, we talked about ED optimization. How can we, by the way, this is what it would look like inside of a EHR. You would have an icon somewhere right here in your EHR. You would just scroll over it and you would see a report like this that you can peruse in about 20 seconds. So very helpful. So when we talk about the SNF summary, you can see the list of things here that a SNF summary will provide. There's more coming. So being able to have a 1 to 2 page summary of their medications, of their that were given in the last 14 days with the last dose given, allergies, code status, diagnoses, why were they there? Were they discharged in the last 30 days? This is all very important information for a lot of our institutions, and especially as we see the advent of value-based care enter into the market of emergency medicine, right? And so having this type of information is incredibly valuable, and it's something as a practicing clinician I really have not seen in my career. And so what's to come? We're working on AI utilization of being able to predict a reason for transfer. So something that says, reviewing the nurse's notes that say, patient fell, hit head, alert-oriented ×3 on Coumadin. Again, that would be really helpful versus seeing the patient that just says fall and they're obtunded in the emergency department and having to do a very non-specific workup, and somehow that patient gets admitted for a chronic hyponatremia of 124, and we think that's why they fell. And the reality is they just slipped out of bed, everything was fine, and they can go back to the nursing home. And again, we're talking about just 10% of these patients that oftentimes is more than we can handle. So we have a booth at 1607. Like I said, I still practice emergency medicine. I'm incredibly passionate about being able from a macro level to share information real time to be able to affect outcomes of patients. I really appreciate your guys' time. I welcome any questions at this time. Yeah, I think the question is, where do we see AI expanding as a business model? I think, the short answer to that is in any way we can take information and collate it into something that's actionable and digestible. I think a lot of times people say that we have an information problem. We don't have an information problem. There's information everywhere out there. It's how do we get the actionable information? And so I think the short cut is, how do we take AI to be able to take records from days, weeks, months, even years in the past, and be able to break those down and bring those into our the way we work inside the ED, and figure out how to really apply that in the best way. I think there's down the road. I think there's opportunities at different charting mechanisms, different ways to create models for how you chart versus I chart within the same system. And be able to provide a more comprehensive chart that actually makes better sense for you and I as the practitioner and the patient themselves. Yep. Right. So the question is, how do you scale effectively with working with health systems as well as post-acute care facilities? It seems very local at times. And how does that, how do we look at a large scale opportunity? I think the answer is, I think you're dead on. I think that it's a hard thing to scale, but I think the opportunities that we should really be dare I say, obsessed with are almost micro environments, right? How do I go into a service area that may have 1 million patients and work with the health systems locally, work with the ACOs, work with the post-acute care, get everybody on the same page? And it may be a state with 5 million people, and I only have 1 million people engaged, but I think that's the place to start to follow that model. I don't think we've had some opportunities to go at a more broad scale, and in some of those locations it works, and in some it doesn't. But in order to get a widespread adoption of this, it takes education, it takes quality improvement, it takes hearing back from the clinicians and being able to say, oh, you need this, you need diagnostic radiology results. Okay, let's work to put diagnostic radiology results. You need MDRO use cases for patients that are in the nursing home with really complex organisms. Let's work on how to do that. And so having that sort of two-way communication between organizations like ours and the clinicians is going to be basically integral going forward. Yes, sir. So this actually, the care facilities are using the EHR of point click care. So there's no extra work when they transfer the patient, when they go into their nurse's notes and say transfer to ABC Hospital. There's nothing else they have to do. It's automatically transferred. Well, thank you guys very much, and have a wonderful day. I appreciate it.
Much.
Yeah, appreciate it.
All right, everybody, please feel free to stick around. We have our innovator meetup in